So let's talk a little bit about insulin drips. So your insulin drips will be managed in the ICU, and insulin drips are used in patients that are in DKA or HHS, so hyperglycemia, right? High blood, makes sense, right? So high blood sugar, insulin drips. And then sometimes they use insulin drip post-op for surgical patients, post-op like cardiac surgeries, post-op, um, or maybe severe uncontrolled hyperglycemia. Okay, so again, only regular insulin is used IV. So IV infusion for insulin is only the regular insulin. So we have Epidra, um, Lispro, Aspart, but only regular insulin will be used for IV insulin drips. Uh, Make sure that if you're priming, I wish I had an example here to show. If you're priming, use the insulin itself to prime your line. Okay, so these are just some general rules for insulin, but make sure you're using the insulin itself to prime the line, not normal saline or anything like that. Use it to prime the line. And then before uh, even administration of the insulin drip, confirm your labs. Okay, so what are your baseline labs? Your baseline labs will be, of course, blood sugar, right? Because you don't want to give insulin for hypoglycemia. So you're confirming blood sugar levels. You want to look at the pH, the BUN, the creatinine. Um, then, of course, you follow your facility protocol when it comes to the insulin drips and all of that. So like if when monitoring the drip, while the patient is on insulin drip, just some key things to remember. Make sure you're checking those blood sugars like every hour. Some facilities will say check every 30 minutes, but every hour is ideal. Check the blood sugars every hour until the patient is stable. uh, Check potassium levels every 2 to 3 hours. um, Also, urine output, we're checking urine output uh, to make sure that a patient is uh, adequate, has adequate output and not. And if you get anything out of the norm, you want to make sure you notify your physicians, your provider. So some of the drips, when titrating these drips, each facility will have a protocol on how to titrate your insulin drips, but most often, like for example, a protocol can be like, if the blood sugar is greater than is above 250, increase, this is just an example, increase by 1 to 2 units per hour. Increase the insulin by 1 to 2 units per hour. If the blood sugar is from 180 to 250, maintain current rate. Or if the blood sugar is from 100 to 140, decrease the rate of the insulin by 1 unit per hour. And of course, if the blood sugar is less than 70, because the less than 70 says it's hypoglycemia, right? You want to stop the infusion and give IV dextro. So that's why these patients are critical, and that's why you probably have just maybe one patient to do all of this. Is a lot of work. You're checking that blood sugar every hour or every 30 minutes, and you're titrating the drips and all of that. So again, follow your facility protocol, and if potassium must be greater than 3.3 before the drip is started. Okay, so if potassium, because what happens is that insulin is going to drive potassium into the cell, risking the patient to become hypokalemic. Yes. So if the potassium is already too low, you don't want to start the insulin drip, because your patient will go into hypokalemia, low potassium levels. Okay. When patient basically with the insulin drips, I'll say follow your facility protocol. All right.